Welcome to listeners from around the world, and thank you for tuning in to this JAMA Clinical Review podcast. I am your host, Dr. Mary McDermott, Deputy Editor of JAMA, and I'm here today with Dr. Atul Malhotra, who is Vice Chair of Research in the Department of Medicine, Research Chief for Pulmonary and Critical Care, Sleep Medicine and Physiology at UC San Diego, and the Peter Farrell Tenured Professor of Respiratory Medicine at UC San Diego. Welcome, Atul.
Thank you for having me, Mary.
Can you start us off by discussing what is the association of sleep and obesity?
Yeah, thank you for the question. It turns out that sleep is a vital part of human health, perhaps not surprisingly, but the data are becoming more and more compelling that inadequate sleep has health consequences. Your mother was right. So we think of three pillars of health being diet, exercise, and sleep, with the dogma being if you ignore one, the other two will suffer. So they're pretty good data that people who are habitually sleep deprived will gain more weight over time than those who sleep adequately. So we had a paper about 20 years ago now from the Nurses' Health Study looking at inadequate sleepers and those sleeping 5 or 6 hours per night gained more weight over time than those sleeping adequately, independent of known covariates. And there's some mechanistic work coming out of Evan Cotter's lab in Chicago that's given some insight into this. If you randomize individuals in laboratory to adequate sleep versus inadequate sleep, the leptin levels are suppressed and ghrelin levels are increased with sleep deprivation, both hormones going in a direction that's predicted to stimulate appetite. And so there may be a mechanistic link between why short sleep leads to weight gain and other metabolic risk.
Can you tell us what defines adequate sleep? How much sleep should people be getting in general?
The definition of adequate sleep is a little tricky because it does vary by individuals. Different people have different needs. The vast majority of people who say, I don't need to sleep or I can stay up all night and function fine, the vast majority of them are incorrect. So the guidelines that we and others have put out suggest that 7 to 9 hours of sleep in a 24-hour period is recommended. And if you have fewer than 7 hours is when you start to see health consequences. There are some individual variations, but the vast majority of people that say they function fine on 5 hours of sleep are kidding themselves.
Your insight describes some other high-quality studies about this association, and there was one, for example, where you discussed that even for people trying to lose weight, that it's more difficult to lose weight when one is sleep-deprived. Could you talk a little about that?
There was a paper in the Annals of Internal Medicine some years ago where they randomized individuals getting adequate sleep or inadequate sleep who are going on a diet. And the idea was if you're going on a diet, you need to sleep adequately for the diet to work. And in that paper, they did observe reduced loss of fat in people who are sleep deprived compared to those who are sleep satiated while going on a diet. So it's something I tell my patients. If you're going on a diet, you need to sleep adequate duration for the diet to work properly. Otherwise, you don't lose as much fat.
And do we think the direction of the association is poor sleep, weight gain, or is it possible that the direction goes the other way?
These are randomized studies, the one in Annals of Internal Medicine, certainly. And so I don't think reverse causation is a big factor there because there's sort of causal pathways that make sense that if you induce inadequate sleep, there are health consequences, including, as I mentioned, suppressed leptin, increased ghrelin, and reduced fat loss during diet.
I wonder if you could say a little bit more about the biology behind the association. Is it mainly the case that with sleep deprivation, there's adverse levels of leptin and ghrelin that makes an individual more hungry, or are there other mechanisms as well?
Yeah, it is complex, Mary, and I think the short answer is we don't know for sure. Certainly leptin is a hormone that's made by adipocytes, and it tells your hypothalamus to stop eating, so it's a satiety hormone. Ghrelin is the opposite. It's made in the GI tract, and it stimulates appetite. And so increases in ghrelin and reductions in leptin would both be predicted to stimulate appetite. The interesting part of that, though, is there's sort of a joke, nobody craves salad at 3 o'clock in the morning. And the reason that's interesting is people tend to crave the worst foods at odd hours, very salty foods or sugary foods, these kinds of things. I don't think that's well worked out as to why. But there are other biological mechanisms, Mary, as you're alluding to, so pro-inflammatory pathways, other things that may have health consequences that are induced with sleep deprivation. So the short story is the story is still evolving here.
And based on your earlier comment, it sounds like some of the association could be if you're awake more hours, then there's more opportunity to eat. But your point seems to be it's not only that. There's obviously these biologic pathways that you've mentioned as well. And your manuscript discusses some more clinically focused explanations, such as arthritis-related pain at night that could make sleep difficult. Could you talk about that?
Sure. There are definitely confounders here in terms of why some people sleep short. Some have insomnia where they can't or won't sleep adequately. Some are burning the candle at both ends because they have young kids or multiple jobs or this kind of thing where they want to sleep more, but they can't because of social pressures. And then there's some that short sleep because they think that's all they need. As best we can tell from the literature, short sleep has health consequences regardless of why it's occurring. And so it's not so much a matter of why you're sleeping short, but the fact that you're sleeping short has health consequences. And yeah, there are lots of factors that can come into play in terms of why that's occurring. The other thing to think about, by the way, is the autonomic nervous system. With short sleep, there's sympathoexcitation, other things that can have biological consequences as well and health consequences.
And so for your patients who have obesity and also sleep difficulty, how do you approach this problem? Often when people have sleep difficulty, it's not so easy to fix that problem.
Yeah, definitely. It is a big issue, and some of this is more art than science, but certainly explain to patients that prioritizing sleep is important is the first place to start. So some people can't sleep more because of social pressures or because of young kids or multiple jobs, but there's others. I have lots of patients staying up late watching Netflix because they enjoy that, and understanding that prioritizing sleep over Netflix can be somewhat of a quick fix in some people. Now, it's obviously hard to change human behavior, but that is one that is worth emphasizing. And if people understand that their diet isn't going to work if they're burning the candle at both ends, then some of them will sleep adequately just to help with their diet and exercise strategy. The other thing to be aware of, Mary, in people with obesity is that obstructive sleep apnea is a very common disease. So we've estimated about 1 billion people worldwide with obstructive sleep apnea. That number is increasing, not decreasing over time, even with GLP-1 receptor agonists and other progress in that area. So if you see people with obesity, be aware of obstructive sleep apnea. So snoring, excessive daytime sleepiness, hypertension, particularly refractory to medications, should prompt an evaluation for sleep apnea.
Your review talks also about an association of very prolonged sleep with obesity. Can you discuss that, please?
Yeah, that's one of these ones that is easy to try to ignore, but it's there in many, many different cohorts that excessive sleep also has health consequences. We don't know why. We have a few papers on that. The very long sleepers tend to have increased risk of depression and certain inflammatory conditions. But we see these patients clinically. I think there's just something different about them. They're often quite socially isolated. They often don't have jobs or families or friends. People sleeping 12 hours are just very different from other individuals. And so I think there's non-specific factors that come into play there. It makes me a bit nervous, though, because we often run around saying, oh, you should sleep more. And then on the backside, there's this potential toxicity of excessive sleep, although I think many of us believe there's confounding factors there or misreporting. But even when you objectively measure sleep duration, there's still this signal that excessive sleep can be problematic, perhaps as a marker of other diseases.
Yes, perhaps depression for one.
That is one factor, yeah.
And then what do we know about treatments that improve both sleep and obesity?
Yeah, so treatments to improve sleep are often behavioral. Like cognitive behavioral therapy for insomnia can be quite good for people that have insomnia, and that involves prioritizing what we call sleep restriction, spending less time in bed, and what's called stimulus control, where you avoid activities in bed other than intimacy and sleep. Scrolling Netflix and doing these things in bed should be avoided if you want to prioritize sleep. In terms of treating obesity, certainly diet and exercise can be helpful. But as I often joke, if diet and exercise were highly effective, I would be skinnier. And so there are other agents now that are coming into play. So we were involved in the tirzepatide studies, the SURMOUNT-OSA, that got FDA approved in 2024 for the treatment of people with moderate to severe sleep apnea with obesity. And that can be quite helpful in terms of inducing about 18 to 20% weight loss with concomitant improvements in sleep apnea severity based on the apnea-hypopnea index. We also pre-specified a number of secondary outcomes, controlled for multiple comparisons. We saw improvements in systolic blood pressure, the so-called hypoxic burden, the sleep apnea-specific hypoxic burden based on the magnitude and duration of desaturations. We saw improvements in high-sensitivity C-reactive protein, which we know is a strong cardiovascular risk marker. We saw improvements in patient-reported outcomes as well. Body weight, as I said, improved 18 to 20%. So if you start out at 200 pounds, 20% would be 40 pounds. So quite a game changer to go from 200 pounds to 160 pounds. And so that's become a fairly common intervention in the sleep clinics as well. So tirzepatide is a GLP-1 with GIP, that's glucagon-like peptide with gastric inhibitory peptide, also known as glucose-dependent insulinotropic polypeptide. And so that's a dual agonist that seems to work quite well for these individuals.
And Medicare will cover tirzepatide for treating sleep apnea, correct? But can you clarify what the FDA indication is? You mentioned obesity, but do people with overweight also qualify if they have sleep apnea?
So it's a little tricky with different insurances have different policies here. The FDA approval was initially for diabetes, and then later for obesity, and then later for obesity in the context of sleep apnea. So people that had moderate to severe sleep apnea in people with obesity. The issue there is it's a little tricky how you define obesity. The FDA didn't specify a weight cutoff in their approval. And so you could argue if your BMI is 28, but you have severe sleep apnea, that you do have a consequence of excess body fat. And so you could argue that is obesity, even if it's not above the cutoff of 30, which is relatively arbitrary. And so the SURMOUNT OSA study that I was involved in, the minimum BMI to get in there was over 30 kilograms per meter squared, but there are patients getting it with lower BMIs if you suggest that they have sleep apnea as a consequence of excess body weight.
For people without sleep apnea, is there any high-quality evidence that the GLP-1 receptor agonists improve sleep quality or duration in those with overweight or obesity?
Not that I know of, Mary. We're just about to publish some data on the sleep architecture, the changes in sleep stages and this kind of thing with tirzepatide. But the majority of what we're seeing are improvements in sleep apnea. So without sleep apnea, are there improvements just by losing weight per se? The answer is I don't know. I don't think that's a big effect when I see these patients clinically, but it's possible.
Is there any evidence that if you help people improve sleep, they will lose more weight? I guess you referred to the Annals of Internal Medicine trial.
Yeah, there are other papers on that as well, Mary. So Ezra Tessali, also in Chicago, did some work on this where she took habitual short sleepers and extended their sleep time. She had them sleep more rather than less, and that did help to facilitate weight loss in those individuals. And so it's not just these epidemiological associations, but there are actual interventional studies now saying that sleeping more can have health benefits.
This was really informative, Atul. Are there any things you'd like to add that we did not cover today?
No, just a couple take-home messages, if I may. I'll again reiterate that we consider diet, exercise, and sleep the three pillars of health. If you ignore one, the other two will suffer. Number two is snoring. Some people think it's funny. It's not actually funny. It can be a marker of fairly important health consequences like sleep apnea. And so if you think you have a problem, go talk to your doctor. And if you think your patient has an issue, dig deeper. It's not one of those things to dismiss or ignore or make fun of. I've had patients get divorced over snoring because their spouses are in different beds. I've had other patients with severe sleep apnea who are amenable to treatment. Nasal CPAP, continuous positive airway pressure, is still first-line treatment, and adjunctive therapies with GLP-1 receptor agonists with GIP can be quite helpful to improve sleep apnea and overall cardiometabolic health.
I'm Mary McDermott, and I've been speaking today with Atul Malhotra about his JAMA Insights on the topic of obesity and sleep. You can find a link to the article in this episode's description. For more of our podcast, please visit us at jamanetworkaudio.com. You can subscribe and listen wherever you get your podcasts. This episode was produced by Shelley Steffens at the JAMA Network. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.